Glad you're here. This is Taylor Riggin,
Correct.
golf pro, golf teacher, everything you want to know about golf.
Everything.
I'll let you can continue.
The topic of discussion today is functional golf fitness and its effects on how you move your body and your golf club, with a little emphasis on how we identify deficiencies and prevent injury. So before we get too deep into that, I have a question. Does anybody ever, first of all, who here plays golf?
He's going to go right here.
All right, good.
He's on
I've got a golf shooting here, so I figured there'd be a lot of you. So let me ask you a question. Have you ever experienced a situation where you knew what to do in the golf swing? You knew how to hit the shot, but you couldn't perform the task. You couldn't execute the shot. Pretty much all of us, right? So there's a few different reasons for that. One could be that we just don't have the knowledge and the understanding, but in this scenario, we're under the assumption that we knew the shot, we knew what to do, we just couldn't do it. The other options could be that we are limited in our physical ability, or there's some kind of injury preventing that motion. And a second could be that we just need more motor training to be able to master that movement. So we're going to talk about those things. But before we get too deep into that, let me go ahead and get a little farther into a little introduction. First and foremost, I am a husband to a beautiful wife, and a father to 3 crazy children who all are celebrating their birthdays this month. So we were busy this month. I'm a lover of golf. I'm a golf instructor. I love what I do. I'm a fitness enthusiast, an amateur chef and pit master. I'm not from Texas. This is not where I was born and raised. So when I came here, I realized I needed to learn 2 things. I needed to know how to bass fish, and I needed to learn how to slow smoke barbecue like Texans do. So I've been working on that for a couple of years. I love to camp and hunt and fish, get outside, and I am a lifelong learner. I like to learn and understand new things, and I take that into what I do as a profession. And that brings me to my professional side. I teach golf. I'm a golf instructor and a coach at Crown Golf, located at Texas Ranger Golf Club in North Arlington. Anybody ever been out to Texas Ranger before? No. Come on out. It used to be called Chester Ditto a ways back, and it was in bad shape. But the city put a lot of money in revitalizing it. They did a pretty nice job. I am a Class A member of the PGA. I started off my career with Jim McLean. If anybody's familiar with who Jim McLean is, he's been a leading golf instructor in the industry for 30 some odd years. Certified through him, and then became a master instructor before he sold his school that was there in Fort Worth. And I said I'm a lifelong learner, so a few of the things that I have or am currently studying include Capto putting, levels 1 and 2. That is, Capto is a putting sensor that goes on your golf club. You hit the shaft, and it gives you all kinds of data points. Wedge Matrix by James Bridger. He is a short game guru to the pros, and he's one of the most trusted guys on tour for wedge play. TPI, that is Titleist Performance Institute. They are one of the leaders in golf biomechanics, and specialize in how the body performs and functions within the realm of the golf swing. So certification in their base level as well as level 2 golf. And I'm also studying the Exos Performance Specialist course, which, again, if you don't know who Exos is, they are how would I say this? Specialize in sports and athletic performance, the training, physical therapy, nutrition. They train professional athletes, amateur athletes. They're very good at what they do. So I'm studying through some of their courses right now. All right, so the question is, what is functional golf fitness? Is it this? Are we here to talk about getting ripped or jacked or shredded to be able to swing the golf club better? Probably not. It's probably a lot more about improving the overall quality of our movement so that we can improve the quality of our golf swing and enjoy the game more. Okay? And so what we have to understand is that when we move properly, and I can identify limitations, we can be able to retrain proper movements. We can improve those limitations and make it so that we can maybe make better contact or create more speed so that we can ball a little farther and make the game a little bit more fun. Because the ball only does what the club tells it to do. And the club only does what the body tells it to do. So we have movement deficiencies or limitations, then that could be causing compensations and things that are less advantageous to the golf swing. And that's what we're going to talk about a little bit more today. But before we go, let's go into a little bit of movement, just kind of the basic understanding of how the body moves. So there's two basic types of movement. We've got translation, so that's moving along a plane. Okay, the whole body moves along the plane. So if I were to move forward and back, or if I move side to side, this is translation. Or we've got rotation, which is just what it sounds like, it's moving around a fixed plane. And there are 6 degrees of freedom. You've heard this term before. There are 3 planes of movement. So the sagittal plane divides the body right down the middle, from the left side to the right side. Anything that moves along the sagittal plane is moving forward and backward, in front of you and behind you. The frontal plane divides the body down the middle, the front half, the back half, and movement along that plane happens side to side. And the transverse plane divides the body through the middle, the top half from the bottom half, and typically refers to rotational movement. Okay. Not super important, but just as long as we kind of have an understanding of how the body moves, and then a little bit of understanding of how the body is made up. The structural portion of our body, we're going to talk about our skeleton, our joints, and our segments. And if you see the body, the image here, it shows that our body is organized in an alternating pattern of stable and mobile joints. So for instance, think about your ankle. Your ankle is very mobile. You can roll that around in lots of different directions. Your knee is stable. It's only going to move in one direction, or it should be only moving in one direction. If it's not, see, yeah, back there. Then you go into your hip. Your hip is a very mobile joint. It can move all around. Your lumbar spine, more stable. Your thoracic spine, more mobile, and so on. So we have these alternating segments, for these alternating types of joints. And then we're going to talk about our muscular system, and I'm focusing more on the skeletal muscles. There's 3 types of muscles. You've got skeletal muscles, and you've got smooth muscles, and you've got cardiac muscles. Those do other things. Today we're just talking about the skeletal muscles and what their purpose is. And those 3 purposes are for movement, support and posture, and balance. And this is really where we start to get into the details of what our topic is today, functional, moving functionally. Obviously just for day-to-day activity, but also for swinging the golf club and being able to hit the ball better. And the way our muscles work is that through contraction, the muscles allow for voluntary movement. So when you think about lifting something or picking something up or giving somebody a high five, you're doing it consciously. You're moving those muscles to create the movement that you want. And that will move the bones and the joints in the form of gross or fine movement. Gross movement is something like running, jogging, swimming, large movements. Fine movement, or within the context of the golf swing, it might be the lateral shifting into your front foot in the downswing of your golf swing, or it could be fine movements like supinating your left wrist to help square the club face, smaller movements. So that's how our body works. Very much a nutshell there, but that brings us back to functional golf fitness. So really it's about how well you're able to move and how well you're able to move the body. And we're going to talk about 3 main topics. That is mobility, stability, and strength. Have I lost anybody yet? Okay, hopefully now we get to talk about the fun stuff. So let's talk about mobility first. Mobility refers to normal joint range of motion and muscular flexibility. Okay, so when you think about not being able to move properly, you're tight, you're stiff, you're sore. So I was born with, as a young kid, I had juvenile rheumatoid arthritis. So every morning I'd wake up and I'd hobble up and down the stairs 1 step at a time because my knees were very tight and very stiff. So in the morning, there's no way I was going to be making a golf swing. It was not going to be happening. I would have to get some manual manipulation. I would have to go through some manual manipulation. I'd have to get some heat and ice and things like that. I'd take the medications that I took, and then I'd be able to loosen up. So I was able to overcome those deficiencies. Luckily for me, it was something that it was temporary, and later through the day, as I started moving, it got better. And as I got older, I went into a remission. But mobility talks about that movement and whether or not you can move. So we've got 2 examples here. We've got a sideline thoracic opener Anybody think they can do that one? That one's pretty tough. Actually, you lay on your side, you rotate all the way over and try to get your shoulder blade to touch, and you come back. And then this gentleman's doing a 90-90 hip stretch. Also a very good one to help create and improve motion throughout your hips. Okay? And so mobility, very important to be able to get into certain or through certain movements and positions in your golf swing. And we'll talk more about that in a minute. We're going to do a little bit of a live demonstration segment here in just a bit. Stability refers to a joint or segment's ability to remain unchanged in the presence of outside forces. So we've got a couple of examples. We've got this guy, he's doing a balanced bird dog where he is creating stability through his core. He should be stabilizing his scapula, raising the arm, extending the leg. Okay, it requires balance and stability in order for him to hold that position. And she is doing a one-legged kettlebell deadlift. Again, creating stability in the hip, in the core, to maintain balance and be able to move through that motion. And that brings us also to strength. Strength is a muscle's ability to apply force and overcome resistance, or the level at which you're able to do that. So if you have greater strength, you can apply more force and overcome more resistance. This is Rory McIlroy. He's in the gym. Many of you may know his name. He's one of the world leading golfers. And then he's doing a weighted lunge for legs. And then over here we're doing a banded rotational chop. Create strength in the core, the obliques, get some rotation in the hips. Okay, so we're going to go through and talk about a little bit of the TPI screens. I talked about the Titleist Performance Institute earlier. And one of the first things that you do as you learn and you study under the TPI system is you understand what they call the body swing connection. And the body swing connection is just what it sounds like. What my body does and how it relates to the way I can move my golf club and hit the ball. So there's a lot of different tests that you'll run through, and you'll help a player run through these tests and screen them to see if there's any deficiencies in their movement. So I'm just going to run you through the list of screens, and then we're going to talk about a couple of them. So there's the pelvic tilt test. There's the pelvic rotation test. Torso rotation. Overhead deep squat test. The toe touch test, 90-90 test. That's actually not the hip, that is referred to the shoulder. We'll get to that a little more later. The single leg balance test, the lat test. That's our back muscles here on the side, the left system's dorsal. Lower quarter rotation test, cervical rotation test, wrist flexion and extension test, wrist hinge up and down test, wrist pronation and supination test, seated trunk rotation, bridge with leg extension, and the reach, roll, and lift test. So there's quite a few that you can run through. Obviously, you may not necessarily do all of them for each individual, but what you're going to do is you're going to look for movements that might be a struggle, and then just run them through a screen and a test. Today, I would like to go through 2 of these with some volunteers. Anybody feeling particularly adventurous today? Anybody? And in fact, I would actually like to have somebody. The first one to do is the pelvic and torso rotation test. So technically it's 2, but they're very, very similar. But I'm actually looking, hopefully, for somebody who knows that they have a little bit of struggle in rotating their body or turning their hips. Is anybody feeling daring to come on and let me run you through a very simple test? Oh, there we go. Come on up. I like it. Very nice. What's your name, sir?
Wayne.
Wayne. Thank you, Wayne. Great to meet you, sir. Welcome. Come on up. So, Wayne, I'm going to have you stand right here facing the crowd.
Okay.
And what we're going to do is we're going to see if we're going to start with the pelvic rotation. Okay. What this test requires is that you're going to get into your normal 5-iron posture as you know. Okay. You're going to cross your arms and cover your hands on your shoulders. And then what we're going to do is we're going to turn. We're going to stabilize your shoulders. You're going to stabilize your shoulders here. And you're going to see if you can turn your hips back and through to the left and the right, rotating them,
Okay.
not not swaying out to the side. So I'm going to let you do it by yourself first.
Tell me if I'm doing it correct.
I will. Okay, keep going. And I'm gonna pick on you a little bit. Does anybody see? I'm gonna give you a demonstration of what it would look like properly done. And I don't mean that negatively. I mean it just so that they can see that. No, actually, what's interesting is you rotate really nicely to one side, and then there's a little bit of.
Oh, I have a hip problem.
There we go. So right away we can see that there's one side that's a little bit deficient. So that would tell me, as your instructor, if I was teaching you, that would give me information to be able to say, okay, well, we have certain movements that you may not be able to perform at all, or you may not be able to perform them now. And then as your instructor, what I would do is I would continue to test the limits of that and find out what you can do comfortably without pain. And then we would have a plan to create your golf swing around those limitations. Or we would send you to the professionals back here to help you create a plan for improving that movement, whether that be through manipulation, whether that be through training and strength and physical therapies and things like that. Correct. So, very good, by the way. Go ahead and do it one more time. We're going to stabilize the shoulder, twist your hips, but keep your chest nice and straight. Yeah, so you've got good rotation on one side. Okay, good. We notice that there's a little bit more of the upper body, the thoracic, the upper body here, the torso, rotating with the lower when he goes to the right side. That's actually not bad. You're getting better at it. Sometimes what you'll see is that the whole body wants to turn together. And when that happens, we're usually looking at the inability to dissociate the two. Usually means that the person just might have a little bit of stability issues. So what I would do is I would hold their upper body, and then I'll let them turn the hips. So he can actually get better rotation there once I help him stabilize a little bit. So there could be a little bit of stability here, but we also have the inability to move through certain motions because of the hip. Now we're going to reverse this. So now this time we're going to, same position, 5-iron posture, you can cross your arms. This time we're going to stabilize the hips, and I want you to rotate your shoulders while maintaining a stable pelvis. Correct. Pretty good. Do we see that there's a better quality to that movement here? He's able to rotate more easily through the shoulders and stabilize the pelvis a lot better here. So there is pretty good dissociation there, better result on that side. So for you, we would probably be looking at what can we do in the golf swing when we make a proper golf swing or an effective movement through the ball. Like pitching to a batter, the pitcher is going to load up on their back foot. They're going to create a lot of stored energy here. They're then going to extend. They're going to step towards the target. That's lateral movement, right? That's that translation. Once they extend and step, they're going to then go into rotation and then throw the arm, and they're going to create a lot of energy and power from the ground up through their body, out the end of their arm, and create a lot of speed. And we do the same thing as a golfer. We set up, we turn and load onto our back foot. We store up all this energy. We shift towards the target onto our front foot. We then go into rotation, and then we swing and release the club, and it's a very similar, it's the same movement. So if he can't move or rotate properly into his hip, we're going to have to find some strategies that will allow him to be able to move effectively and still get good contact. And that's my job as your instructor, and that's their job as the medical professionals to help you build a plan to improve that.
Very good.
Wayne, thank you very much. I appreciate your coming up to volunteer. Could I have one more volunteer? Oh, wait, I forgot. We have, you don't have to sit, you can go ahead and sit down. We have some fixes, by the way, some exercises or things that you can do to help train that movement or to find out if we can get better movement. And one of those would be what's called a shovel pass. All right, so imagine you're holding a weighted medicine ball, and you would take this ball and you would kind of step toward the target. You come down low like you're shoveling the ground, and then you would toss it. And you'll notice when I do this, I'm creating some rotation and movement through my hips to lead the way. My legs push off the ground, and you toss it to the left. You do it again to the other side, to target the other side, and we're creating some dissociation and some power through the hips into that movement, similar to the golf swing. Another one is called the hip twister, okay? Or side step-ups. Side step-ups are also called the, wait for it, it's coming. The Heisman move. So what you're doing is you would step up onto a small step next to you, and then you would twist and bring the knee across you. So your hips would rotate, and you get to this position where your chest still looks this way, but your hip comes across. And you would target that rotation, that dissociation where the chest and the upper torso stay more stable, and the lower body and the pelvis rotate across. So those are some different ways that we can get some work on that rotation and see if we can't learn to move that way. I've got one more demonstration that I'd like to do. This is for the 90-90 test. This is for shoulder external rotation. So does anybody here willing to come up and be my guinea pig for a moment who might have limited shoulder rotation? Rodney, come on up, buddy. Perfect. All right. Thank you, sir. Awesome. So here's what we're going to do. We're going to have you stand. Actually, we're going to have you stand this way so that the audience can see. We're going to lift your arm out to the side, straight out. We're going to put your elbow at a 90-degree angle, palm to the ground. We're going to keep that stable. And what we're going to do is we're going to rotate around this point here. And all I want you to do is rotate it back as far as you can go without getting any extension in the spine. Rotate that as far as you can. Okay, freeze right there. So you'll notice here, ideally, we're looking to try and see if we can't get to about 90 degrees or straight up and down in the forearm. If we can, that's a pretty typical range of motion. If we're short of that, which we can see that he is a little short of that, then we're under rotating externally. This is the external rotation of the shoulder. And if we can go farther than that, I'm not going to push him under that position because it's probably going to hurt. So we're going to go as far as he can without pain. And if we can go past that position, which for me I can in my right side because this is the trail side where I hold the golf club. My left side I'm actually not as flexible. So go ahead and rotate around this way. Let's go to the other arm and see how we stack up. On this side, same thing. Good, nice and flat, and rotate it back. We got more range there. That left side is a little more, so you're right at that 90-degree angle without any extension of the spine. So we can see that for him, his right side is going to have less range of motion. Now I taught, thank you, you go ahead and say thank you very much. I taught a gentleman the other day, he came out for a first lesson, and immediately I noticed that the club looked a lot like this. And for those that may not know, that's not an ideal position for the golf club to be in because it's very difficult for the club to get back to the ball. So he would get here, and then because of the way his shoulder was limited, he would have to kind of stay in close to his body, and then he'd rotate through here, and he'd kind of chicken wing. It was very difficult because I had him go through that test, and he was able to get to about there. And that's where he stopped. And I was actually on both sides. So he and I started to devise a plan, same kind of idea. We needed to find out, okay, is it because of injury? Did he have a surgery? Is there an overdevelopment of his internal rotators so that they're very, very tight going this way, preventing motion here, that we can loosen those things up through some stretching, manual manipulations. We had to figure out what it was that was causing the issue because for him, what it was is that he was very, very tight. He had very limited motion because of injury. And so for us, we started talking about some stretches that he can do at home, for instance. And this was not where he was going to start because he's not able to do this yet. But you could take this, grab the club head behind you. And for those who want to just kind of continue to stretch that rotation, you just bring that back softly until you find that spot where it starts to have a little bit of resistance, and you stretch it out a little bit more. That's a stretch. You can also do some massage manipulations in here. If you get a lacrosse ball, start to work it right in here underneath and get into the calf of the shoulder, back here, across the backside, and into the scapular area, all around this area, and start to get some of those pressure points where it starts to release the tension of the muscles and allow for greater range and mobility. So, again, my job as the instructor is to help identify what those areas are, why you're not able to move, and see what the issue is, and can we build a little bit better motion out of that. So some ways that we can get increased mobility, we can do what's called push pulls. So you would grip your fingers together and you would pull apart as hard as you can. While you pull apart, you're trying to separate the hands, but you're not going to let them. Then you push together as hard as you can. Pull apart, push together, start going to rotations, backwards rotations, swimming forward, all while still pushing, backward swims. Do some of these, and now go pulling, same thing, go through all those different motions, backwards, swim it back, swim it forwards, push, pull, and you go through the prescribed reps and sets. And that starts to allow you to create better motion there. Another one, really, really good one, 90-90 box press. So you would put your arm out. Let's say this is the shoulder that you're working on. You put your shoulder out in the same position that Rodney had his arm in. You would then actually put this arm out at a 90 degree also, and you start with hand vertical, thumb up, and you would lift as hard as you can while applying force down. Palm down, lift as hard as you can. Thumb down, lift as hard as you can. You go to the top, thumb up, down as hard as you can. Palm down, down as hard as you can. Thumb down, down as hard as you can. You repeat that on the other side. Again, for the prescribed reps and sets, you start to create better strength, movement, start to loosen those things up. And those are just ways to kind of help create better rotation, because obviously if we are not able to get from here to here, we might have some difficulty in getting the club on the plane. So he was internally rotated and he could only do so much with his wrist. So he had to have a much more upright golf swing. And that's okay, we can work around those things. Okay? So our job and your job is to, when you go take a lesson with your golf instructor, if there's some kind of movement that doesn't feel tight, painful, limited range of motion, anything like that, speak up and let them know, because for us, as we understand the way you're feeling, it helps us be able to more effectively create a plan for you to be able to get more enjoyment out of the game. Plus, we can send you to the people who really know what they're doing to help fix those issues, create more comfort, first of all, so you're not in pain, and allow you to be able to get that ball skyward and onward and into the hole in fewer strokes. One last thing I have for you is, do you have any questions? First of all, I have a question. I'm going to start the Q&A off. Does anybody know?
Coeur d'Alene.
I'm impressed. I'm impressed. Have you played it?
Yeah.
I used to caddy it.
Oh, yeah?
Yes. So if anybody, does anybody else know where this is? This is Coeur d'Alene, Idaho. This is the Coeur d'Alene Resort. This is the world's only movable floating green. So this little boat, it's called the putter boat, goes back and forth and brings golfers to their ball. Hopefully they hit the green. And they can control it inside because this green is a massive green. It has a pulley system underneath the water and an engine room, and they can move it into as close as like 130 yards and as far out as 200 yards. Not while you're hitting the ball. Which but yeah, it was a very fun place to work. It's beautiful up there. Anyway, I'm impressed. And you knew where it was too. Have you played it?
No, I'm not a golfer.
Okay. All right. So, does anybody have any questions about functional golf fitness, the mobility of the body, the movement structure, and the way we move the club in our golf swing?
Do you have any printouts of what you showed us?
I can send you a copy of this. Yeah, absolutely. Anybody else? So here's my last thing I want to tell you. First of all, thank you. Thank you for having me. But the last thing I'll say is, if you love playing golf, go see your instructors here and just keep getting better. Never think that you're done learning. So keep out there, get out there and enjoy the game more, and talk to these guys about how you can move better. And you guys have a fantastic afternoon. Thank you so much for having me.
Thank you, Taylor. Scott had to step out, so I'm going to fill in. My name is Laura Redmond. I am the marketing director for North Texas Orthopedics and Spine Center. We've been in practice 34 years. We have 2 locations, off of 35 in Heritage over in Keller Alliance, and off of 114 in Irie Woods over in the Grapevine South Lake area. And Dr. Casey Stuhlman is one of our orthopedic surgeons. and he's going to talk to you about some golf issues that can occur with hip pain, and he will also leave the floor open at the end for any Q&A about any kind of orthopedic issue, and we treat everything from neck to toe. We have 14 subspecialists at our practice and over 100 staff members, so we can take good care of you.
For being brave, while he's getting himself fully set up. Wayne, would you like a hat or a practice putting target?
Well, I can just speak louder if that'll work, okay? All right, so I'm a board certified fellowship trained orthopedic surgeon, and so I did my fellowship training in sports medicine, and I trained in residency at Mayo Clinic in Rochester, Minnesota, okay? My practice consists of roughly 50% total joints and then 50% sports, okay? And so my charge today is to talk with you about hip pain on a golf course, okay? And so our goals today, we're going to review pain around the hip. We'll look at general anatomy in the area around the hip, discuss how you can treat some of the causes of these pain, and then discuss when it's probably a good idea to come in and see some professional help, okay? So as a way of introduction, we know hips are vitally important. And so in the golf swing, they help maintain fluidity. They're important for weight transfer, and that's where you generate a lot of your power. But unfortunately, it's also a major cause of pain in the golf swing. That's due to the repetitive nature. If you ever go and hit a large bucket on the range, you do the same thing over and over and over. The rotational torque, and then the complexity of ball striking, timing, and if you've all been there, you hit a ball fat, you hit a little more ground than ball, your body keeps moving, the ball, your club stops. It's a quick way to cause pain in your hips. As we look at the anatomy of the swing, really the main muscles I would say are probably the core. You use a lot of your core. But I'd say one of the most important muscles aside from that is just generally around the hip. And so we're going to dive a little bit into this. But one thing that I want you to take from this is that not all pain that you feel at the hip is actually from your hip, okay? And so there's multiple causes of pain around the hip that you'll feel in your hip, but it could be from elsewhere. And so as you notice in the little diagram here, the orange arrow is pointing to the inguinal groin stripe is what we call that. So think of it as where a Speedo or a bikini would sit. That's where you really feel pain from your hip joint. Pain elsewhere around the hip is actually not from your hip. We'll dive into a little bit about this, okay? So as we look at this, just as we discussed, pain in the groin is often your actual hip joint. Pain in the low back can either be your back or what's called your SI joint or sacroiliac joint, okay? Pain further down in the buttock is often the sciatic nerve. And then pain around the side of the hip, which is probably one of the most common causes, is soft tissue, or what we call trochanteric bursitis. And so again, this is another way of looking at it. So if you look at the pain on the left, you can see there's a red dot there, and so that's soft tissue pain. That pain sometimes will radiate down the leg, but it never goes below your knee, okay? If you look at the middle picture, that's that bikini that we were talking about, and that is actually the hip joint. If you feel pain in the groin, that is actually coming from your hip joint, okay? Whereas nerve-related pain will frequently go all the way down the leg, okay? So we'll start by talking about lateral hip pain. So this pain is localized over the side of the hip, okay? And so if you feel your hips, there's a bony prominence on the side of the hip. That's called your greater trochanter. And so again, pain there will either be localized there or partly radiate down the leg, but it'll never go down below the knee. That's often related to an area called the bursa. And so, I don't know if you can see my mouse here. So this bump on the side of the hip here, that is your greater trochanter. And so that bony prominence has multiple muscles that then slide over top of it. So there's a thing called a trochanteric bursa, which allows those muscles to slide back and forth. Okay, it's a lubricated fluid-filled thin sac that allows things to slide over top of the bony prominence. You have bursa all over your body. You have your elbows, you have your knees, you have them elsewhere. But in the hip, that's a common source, probably one of the most common sources of pain. Okay, and so anything that ends in itis, that means inflammation. So we just said trochanteric bursa, so this is called trochanteric bursitis. So those bursas in the side of the hip become inflamed. And so what would you experience? You'd experience pain on the side of your hip. You commonly feel it when you lay at night on the side, or when you first stand up. When you first take your first few steps and transition from standing to walking, you have kind of a dull, burning pain on the side of your hip. Frequently will go away with time, okay? And then some people may experience pain with crossing their legs. So the initial treatment, so you start developing pain on the side of your hip, well, what do? I would say you would first and foremost talk about NSAIDs. We'll dive a little bit more into this in a second, but they come in two versions, oral and topical. And I'll briefly stop here to talk on Voltaren. This is a topical anti-inflammatory that was previously a prescription, now is available over the counter, okay? It actually used to be quite expensive. We used to get calls from insurance companies to do peer reviews because they would deny it was so expensive. Now it's really inexpensive, or let's just say relatively inexpensive, and you get a toothpaste-sized tube of it, it's over the counter. This stuff works very, very well, okay, for soft tissue pain. And then with bursitis, I would typically recommend using a heating pad, okay? A heat of some sort. So if you have a hot tub or a jacuzzi, if you can soak in that, that works very well for trochanteric bursitis. So oftentimes when patients come to me, the hip's been hurting for just a few days, this is usually what I recommend. Let's start an anti-inflammatory. I recommend putting the Voltaren on the side of the hip, and then I would put the heating pad on top of that, okay? And what that does is actually vasodilates and makes your blood vessels larger. It helps that soak in, okay? Now, what are NSAIDs? We just talked about NSAIDs, so that stands for non-steroidal anti-inflammatory drug, okay? Anti-inflammatory is the key. So with NSAIDs, it's actually decreasing inflammation. We talked about the itis. The itis of bursitis is inflammation. We're trying to get rid of the swelling. So over the counter, this is Aleve, ibuprofen, Motrin, but it's not Tylenol, okay? Acetaminophen and Tylenol are not anti-inflammatories. They work well for pain, but they only work centrally in the brain. They do not decrease inflammation, okay? Now, not everyone can take NSAIDs, and so what are some reasons you may not be able to? That would be if you had a heart attack or a stroke, okay? If you have a history of a bleeding ulcer in your stomach, or if you have kidney disease. And certainly if you're ever uncertain, just contact your doctor first, okay? Now, we'll step back and talk about Voltaren. For even people who can't take oral anti-inflammatories, Voltaren is safe, okay? That is something that you can do. One I failed to leave on here is blood thinners, okay? If you're on a blood thinner, like Plavix, okay, Eliquis, or Xarelto, you shouldn't take anti-inflammatories because that'll thin your blood further, okay? The risk of that is if you fall and hit your head, you can have a head bleed, okay? So back to trochanteric bursitis. You've tried that, you've done the heating pad, you've taken some ibuprofen, it's been 2 to 3 weeks, it still hurts. That's when we'd recommend coming in and seeing us. So what would we do at that point? Well, we try physical therapy, but the thing that works the best is a cortisone injection, okay? So cortisone is a steroid. That's an anti-inflammatory we can directly inject into that bursa, and that significantly reduces the pain there and really calms it down, okay? So now I'm talking about posterior pain, so pain you feel in the back of the hip. So if you find you have localized pain in the back, okay, not generalized pain, but just point specific, like she's pointing there, all right, it hurts with sitting, and then you notice it when you lay down. That often is related to your sacroiliac joint, or sometimes we'll shorten it to SI joint. So the sacroiliac joint is where the sacrum and the iliac wings come together in the back. We call it a joint, it's not truly a joint. It's a static location, there's really no movement there, okay? It's stabilized by ligaments, it's very stiff, but occasionally with golf, with an injury, you can get a little motion, get it out of place, and it can be quite painful, okay? So if we have inflammation in it, then we see that ugly itis again, that's sacroiliitis, okay? So 2 causes of pain there are either a sprain of the ligaments, or more commonly, arthritis in the joint. Now we just said there's not a whole lot of motion there shouldn't be, but you can still develop some arthritis there, okay? And it's characterized by pain where the underwear sits in the back and it's very focal. You can point right to it, okay? Again, initial treatment, oral anti-inflammatories or topical, and a heating pad or a hot tub. I think we're starting to see a little bit of a coincidence here. You'll see this time and time again. This works pretty well, okay? And so when do you see help? Again, you try this 2 to 3 weeks, it's not getting better. And again, this time we would talk about physical therapy first, but if that doesn't help, then typically we would do an injection. But this is not an injection we do in the office. This one requires guidance, and so we have to use X-ray to guide this one, and we have specialists that do this, okay? If you have trochanteric bursitis, that's an injection. You come in and see us, we'll do it right there in the office, okay? Posterior leg pain, so that can basically look like any of these pictures. You can have pain across the low back, you can have it across the back of the thigh, or it can go all the way down the leg. This is commonly associated with the sciatic nerve, okay? So the sciatic nerve is a large nerve, it's about the size of a garden hose. It comes from your low back, travels across your buttock, and goes down your leg. If you have inflammation of this, it's called sciatica. The common causes are either a pinched nerve in your back, okay, or arthritis in your back. Either way, that's causing a crowding of the nerve roots that form the nerve. And so what you would typically feel is numbness, tingling, or burning. If you feel pins and needles or burning, that's a clue right away that you have a nerve issue. Okay? So initial treatment for this is modifying your activities, anti-inflammatories, heating pad, rest. If that continues, then typically we would try a stronger medication, which would either be an oral steroid or muscle relaxer, which are prescription strength anti-inflammatories. And then we would also have you try some physical therapy. Now, the physical therapy really emphasizes and focuses on your core, okay, your abdomen. If there's no improvement after 4 to 6 weeks of that, that's when we would get either an MRI or a nerve conduction study. The reason to get that is that guides what's the main treatment for this, which is a guided injection. So you see the image down here, this physician here is using X-ray to guide an injection. And the injection is based on the level that you have a pinched nerve. Surgery for sciatica is rarely necessary. 90% of this will go away on its own, okay? And sometimes it can be a bit of a bugger though and hang around, okay? So sometimes it's just you have to stick with it. But surgery is an absolute last resort, okay? But what would really guide that is the MRI, okay? Now, lumbar radiculopathy, that's the generalized term for a pinched nerve. Classically, we think of sciatica going down the back of your leg. It doesn't always have to go down the back of your leg. These pictures on the picture on the side shows what's called dermatomes. And so that's levels that each level of your spine correlates. So if you get a pinched nerve in your L3, you're going to feel like going down the front of your leg. And so each spine level correlates to a different area in your back. And so location matters. And so just because you have pain that comes down the front of your thigh, it's burning, it's tingling, that doesn't mean you don't have quote-unquote sciatica, but you probably have a pinched nerve. Other causes of pinched nerves are what's called piriformis syndrome. So there's a couple muscles in the back of the head called your piriformis muscles. That muscle sits directly on top of your nerve, and if that nerve muscle is tight, you pinch the nerve and cause symptoms that are very similar to sciatica. That's if you do your conservative measures, you do everything with physical therapy, it's not getting better. They get an MRI of your back, and voila, there's nothing in your back, okay? So what leads us to that is doing what's called a nerve conduction study. We can place little probes in your foot, and then that can tell us where the nerve is pinched, okay? So the mainstay treatment, very similar to sciatica, but we really emphasize physical therapy, and now we're really working to stretch, okay? The issue is not in your core or your back, it's in those muscles. We need to loosen those muscles. Other causes of pain down the back of the leg are frequently related to your hamstring tendons. Again, this never will go below your knee. You will not feel numbness, you won't feel tingling, you won't feel pins and needles. You have pain with sitting. So there's 4 hamstring tendons, okay? Semimembranosus, tendinosus, and then you have the biceps femoris has 2 heads. The function of the hamstring is to extend the hip and bend the knee. Okay, so that's extending the hip and bending the knee is the main function of the hamstring. That's important because injuries to that commonly occur when you do the exact opposite. When you have a forced flexion of the hip, okay, or a forced extension of the knee or flexion of the hip. That will lead to this pain, okay? This is what we commonly call a pulled hamstring, all right? Usually it occurs in the middle 1/3 of the thigh, and you'll have some kind of bruising or swelling in that area. This usually comes with a tearing or partially straining the muscle belly. That's what you get the bruising with, okay? Now you've seen me say heat multiple times. Anytime you see swelling or you see bruising, that's when we do ice, okay? Ice will vasoconstrict. It does the opposite of the heating pad, and that will help minimize swelling. So if you have swelling in a joint or swelling someplace, then you want to do ice. Heat works very well for muscle or soft tissue things. With this, again, anti-inflammatories. If it's a severe pull, sometimes we'll do protected weight bearing. If Physical therapy and stretching are really the key for this. At the top end of the hamstring, this inserts to the bottom of the pelvis, which is called the ischial tuberosity. So if you've ever had somebody sit on your leg, it feels like they have a really bony bottom. That's the ischial tuberosity. That's where your hamstrings insert. So if you pull or tear the hamstring in that location, it's excruciating to sit. Not sure what happened there. There we go. So if you get bruising with this, it's substantial bruising. You saw a little bit of bruising on the last slide. So let's just get a little bit of bruising in the back of the thigh. This is massive bruising all the way down to the leg. As you can see, this poor gentleman here has what's called a Popeye. So you can see the muscles even balling up down there. Okay, so these are severe injuries. These are pretty rare involved. Honestly, these are probably more common in water skiers. When they're trying to get up from the water, that's usually when we see these.
Cable a little loose.
All right, I apologize for that, guys. So again, treatment for this classically is conservative, okay? Surgery for this is pretty much limited to really high-level Division I athletes, professional athletes, and the reason for that is because the surgery is miserable. You have to make an incision at the bottom of your gluteal fold. You have to leave your leg bent for 6 weeks without straightening it out at all. And then the incision is down by the bottom, so it's kind of fraught with infection and wound-healing issues. It's a miserable surgery. Okay. Groin pain. So the adductor muscles of the groin are muscles that attach to the thigh, and they attach to the front of the pelvis. And their job is to bring your knees together. Okay. And so if you strain your groin, you tear or partially tear the muscle belly. This is classically a clinical diagnosis. It's point tender. You may see bruising in the area. And again, if you see bruising, what do we do? Ice or heat? Ice. All right, works with resisted abduction, right? And so, initial treatments, activity modification, do the anti-inflammatories. You guys already know to do ice because there's swelling and bruising there. Do that for the first 2 to 3 days. At that point, it's okay to then switch to heat, okay? Conservative treatment for about 2 to 3 weeks. If it's not getting better, the mainstay of this is physical therapy. We'll get you set up with a physical therapist and maybe give you a stronger prescription anti-inflammatory or muscle relaxer, and this will go away on its own. These are supplements. All right, this is the one probably most people came here to see is arthritis. The one called arthritis, okay? So other cause of pain in the groin is arthritis. And so classically you feel this in the groin. Remember we talked about if it comes from your hip joint, you're going to feel it where a bikini or a Speedo would sit kind of along your groin. 2/3 people will experience pain when they're up, standing, weight bearing, it's in the groin. 1/3 will actually experience this back in the buttock area, but it doesn't radiate down the leg, okay? So what is arthritis? So if you look at the picture on the left, the joint has healthy cartilage on the end of it. The cartilage's job is just to make things frictionless and glide around smoothly. Rubbing cartilage against cartilage actually has less friction than ice against ice, okay? But over time, that cartilage starts to wear down, and you get some roughening or areas where you have exposed bone, and that creates arthritis. Your body wants to regrow something, but you get one set of cartilage your whole life. You can't grow more cartilage, and so you grow bone spurs. So if you hear people talk about bone spurs, that's what these are. Your body's trying to grow something. So they don't cause pain, but on x-ray, we see large bone spurs. That gives us an idea that you've got pretty advanced arthritis. So I liken it to tread in a tire, okay? So when you're young, you have a big, tall tread. Over the years and miles, it starts to wear down, and eventually we're on ball tires, okay? So with arthritis, conservative measures, we rest, we modify our activities. And so we talked a lot about NSAIDs. There's other forms of anti-inflammatories, and I'll touch on this in a little bit. That's turmeric or turmeric, which is a cooking spice, okay, and fish oil. Now, oftentimes people want to know more holistic or natural ways to get anti-inflammatory or other over-the-counter meds. One thing to keep in mind with herbs or supplements is they do have medicinal properties, okay? So even though they're not regulated by the FDA, it is still a medication, but it can affect some of the other meds. So it's important to consult your doctor before you just start random supplements, okay? The other thing is they're not regulated by the FDA, so you could be getting turmeric or you could be getting sawdust. You don't know, so that's why you have to buy it from a reputable source, okay? Low impact is the key. So with arthritis, it's best to ride a bike, do a elliptical, over running and jumping or higher impact things, okay? Physical therapy and gait aids. So gait aids can be a walker or a cane, but it can also be a walking stick. It can be other forms that can offload the joint. And importantly, weight loss. It's a subject that sometimes is a little taboo, people don't want to touch on, but if you've got bald tires, sometimes it makes it a little easier to take a little load off the vehicle, right? So, now, you do conservative things, it's not working, you're having a lot of pain, what do we do? Well, the definitive treatment is a hip replacement, but in between, there's something we can do. We've touched on injections, but I'm a big fan of a hip injection in the hip. And the reason for that is it can be diagnostic as well as therapeutic. We've talked about there's multiple reasons you can have pain around your hip, and one clean way to kind of delve out where your pain is coming from is to do an injection into the hip. Now, in that picture that we looked at before, you can see there's a capsule that goes around your hip right here. So if we inject a numbing medicine into that, that will effectively numb any pain that comes from that for about 6 to 8 hours. And so therefore, it serves as the test drive for a total hip. So for those first 6 hours after that injection, the degree of relief you get after you get an injection is what you experience after you had a total hip. Okay? So that's the diagnostic standpoint. The therapeutic part is that we also inject a steroid that can last for up to 3 months of relief. Okay? And then the definitive treatment is to do a total hip arthroplasty, commonly known as a hip replacement. Okay? So that's where we replace the worn out ball and socket. And so this is actually one of the most successful surgeries of all of orthopedics. Okay? There's lots of people who get knees, hips, and I would say hips tend to do the best of all of them. There's a thing called a forgotten joint score, and oftentimes patients will forget which side they had replaced. With a knee replacement, unfortunately, you never really forget which side. It just doesn't feel like your native joint. Okay? So what do you expect if you have a hip replacement? It's a single night stay in the hospital. Some people are starting to do them as outpatient. Most people stay one night, and I would probably recommend stay one night, take advantage of the nursing and getting help, okay? You're up and walking the day of surgery. So the day you have it, you're up and walking, and the next day they get you out in the halls, and you're walking around the halls. Typically, you're on a walker for about a week or two, okay? And now I didn't mention in here, it's a little bit outside the scope of this talk, but there's different approaches. One that's popular is the direct anterior approach. That's where we don't take down or remove any muscle. When we do the direct anterior approach, classically, I'll have patients that come back and see me in a week or two and aren't even on a cane anymore, they're just out and walking, okay? But we do quote it as a 3-month recovery, okay? So restrictions, for the first 3 months, classically we tell you don't cross your legs, don't sit in a really low chair where you're bending your hip greater than 90 degrees, okay? And the reason for this is it increases the risk of the ball popping out of the socket, all right? The different approaches come with different dislocation rates, but again, coming from the front of the hip, that greatly reduces this. Oftentimes with my direct anterior patients, I really don't tell them. I mean, this is more of a suggestion, okay? Now, if you go from the back, this is law. We have to do this, this will increase the dislocation rate. But after hip replacement, you're able to return to activities, okay? So over here, you want to go back to golfing, right? You can also go back to doubles tennis or pickleball is another very popular sport that's really picked up. Snow skiing, you can go ski greens and blues, okay? Just watch out for the other people in the greens and blues, some people that don't like ski. Biking is actually probably one of the best forms of exercise when we talk about arthritis. Whether you do hip replacement or not, if you're somebody who's a former runner, I would highly recommend converting to biking, okay? Whether it's a stationary bike or an outdoor bike, biking is very hip friendly. And so that's, again, we talked about, even after hip replacement, we want to avoid high impact things, running or jumping, because it's metal and plastic. One thing I did touch on is how long do they last, and that's what commonly people want to know. We quoted about 20 to 25 years, right? But that's because we have 20 to 25 years of experience with that plastic. For most people, we'll put one in, it'll probably last you the rest of your life, okay? They're very long lasting as long as you follow the rules. Now, if you go out and run marathons, it may not last as long, okay? But in summary, golf can really be a pain in the rear already, so we just hope that this helps get rid of some of the pain in the hip. Hopefully this will kind of tell you what some of the different pains around the hip, how to treat them. Okay, now you guys know at least ice and heat, when you use it, it's a common confusion, okay? And when to seek help. You guys have any questions? Yes, sir.
I presume pickleball will extend the life of that, your regular hip joint, right?
Pickleball, oh yeah. No, but in all seriousness, it's a great sport, and it's really picked up in popularity, but it's great. I mean, you can feel free to go back to pickleball, or like I said, doubles tennis. Playing singles tennis is probably a lot to ask for that hip, but
So does, prior to having any operation, does pickleball tend to shorten your life of your natural hip joint?
pickleball, I'd probably say no. I think more high impact things would. Now again, if you're falling in pickleball, that's going to inflame things. But I think you should feel free, if you've got maybe a little bit of arthritis in your hip, I wouldn't worry. You can feel free to play pickleball and golf and things. But just know that sometimes, if you golf like me, do a little bit of military golfing, where you're left, right, and all over the course, you're probably going to pay the price the next day, and the hip's going to be a little bit sore.
Since he opened it up,
Yeah.
pickleball,
Yeah,
does it affect the knee more so than anything?
a little bit because of the twisting.
Okay.
Yeah, and so that can inflame it. Now, I don't think it's going to make your arthritis worse. Okay, but with arthritis, sometimes you'll have arthritis in your knee, you don't even know that it's there. I use the analogy of an ant. You get an ant in your yard for months, you never know it's there. But if you kick it, you become acutely aware it's there. So, twisting and turning, high impact activity sometimes can flare that up, where you realize the arthritis becomes more apparent.
2 more questions and then I'll shut up. So the other one is, does the pain have to be consistent in order to be determined as an issue? Does that make sense?
Yes. So I think that's kind of the point of, try some of those anti-inflammatories, if approved by your doctor, or some of the conservative things we talk about. I would try that at home. If it goes away, I think you're fine, okay? But it's when it's persistently or recurrently happening, or it's not going away with those, that's when it's time to come to this.
Okay, where does Advil fall into that?
That is an NSAID. So everything other than Tylenol,
Okay.
acetaminophen, Tylenol, and Excedrin, okay? Those are not anti-inflammatories. Naproxen is.
What about taking it on a daily basis? I've heard that it can affect your liver.
So more probably than your liver. So Tylenol affects your liver. The kidneys is the anti-inflammatory. So if you have baseline kidney disease, or if you have any issues with ulcers or reflux, that can definitely affect those. There's some prescription ones that tend to be a little bit more GI friendly that maybe a little bit outside the scope. There's 2 enzymes that affect inflammation, COX-1 and COX-2. Everything over the counter, Aleve, ibuprofen, Motrin, naproxen, they all affect COX-1. COX-1 also controls how thick your stomach lining is. So that's why those can tend to irritate your stomach. They take away inflammation, but they thin your stomach lining. The only one that doesn't affect your stomach lining is Celebrex, okay? That's a prescription. Or there's meloxicam, which is a little bit of a hybrid that tends to be a little bit stronger. And so those 2 are ones that you would get from us. Okay?
Thank you.
When you say thins your muscle line, are you saying
Stomach line.
Your stomach, are you saying temporarily or?
Yes. Yes.
Not permanently?
No. Yeah, just temporarily. And that's why if you take anti-inflammatories on an unregulated, everyday basis, it can cause ulcers in your stomach. Generally, the rule of thumb is it's safe to do it for about 2 to 3 weeks. Okay? If you're going to do any more than that, you'll probably talk to your doctor. If you come see me, I usually put you on a prescription for a month, but I tell you take it for 2 weeks and then take it as needed after that. Yes, sir.
You have a handout for some of the presentation you gave?
I don't, but I can give it to Laura, and she can send it out to you guys if you'd like it. Okay. You got Uncle Arthur there.
Yes, I heard of this oral steroids.
Oral steroids?
Yeah.
In terms of,
Like for instance, you got lower back problems, 5, 4, 3, 2, 1 type.
yeah. And so generally what I would, if you came and saw me and you had some sciatica and just kind of started, that's where we start, okay? Is usually I'll do a Medrol dose pack, which is the taper you're referring to. Where you take 6 pills the first day, and 5 on the second day, 4, and you kind of taper down. And so those are okay on an intermittent basis, and that's something you want to continue to take, an oral steroid. And that's why we prefer to inject steroid versus take it orally, because it can have other effects.
With lower back pain, nothing going down the legs, that can be reduced by sitting Indian.
Yes.
Is that telling you anything about what is wrong?
Does it go all the way across the low back, or is it kind of localized to one side?
It's mostly on one side.
Yeah, so that may be your SI joint, okay? Because when you sit Indian style, you're relieving the pressure, and that kind of opens up that joint. You get some little micro motion. A quick tip I would recommend to try to readjust or reset your SI joint. If you come here, I'll show you.
Never mind.
This is just something you can do at home. It's nothing, you just have a seat right there, okay? What I want you to do is I want you to put the back of your, so spread your leg, just kind of follow like the line. So put the elbow on this thing right here, and then put your fist on this thing right here. So kind of open your legs, so make it a firm fist right there. And now squeeze your knees together, really squeeze, and you'll feel kind of in the back. You feel that? So you can do that, and sometimes you can maybe feel a pop, and it's just resetting that SI joint. So that's a quick way to try that. Okay?
Both sides.
Both sides.
What did you do?
Can you show it?
Yeah, so all we did is I'll show you here. So what we're doing is we're sitting, okay? And then you just kind of open your legs and you put the back of your elbow on the inside of this knee here. You put your fist here between the knees here. So it's just giving it kind of a firm spot. And then you're really going to squeeze your knees together. When you do that, you'll actually feel the pressure in the back, okay? Because the SI joint, you'll feel it kind of open in the back, and maybe you'll feel it kind of pop or reset.
Is that the same way as squatting and just putting your elbows? Or is it that different?
This is a little bit different, because if you look at, like I'm showing you the anatomy of the SI joint, so really what we're doing is we're squeezing our legs, and what that does is it kind of springs the hips open, and it's kind of decompressing here. You can feel it, because like I said, it's not truly a joint, but if it's off even just a micrometer, you can feel it, it's uncomfortable. If you can reset it, sometimes that can give you some pain relief.
But your recommendation for how to work at fixing that is an injection?
That would be if doing anti-inflammatories, heating pad, doing some of the local stuff. I would rub Voltaren on it, do the heating pad, stretch, okay, and maybe even try yoga, do the reset. If it's still bothering you after that, then that's when you'd come see one of our providers. We have 4 different PM&R physicians that do guided injections for that exact reason. Okay. Yes, sir.
I had a question. Through the years, I had on and off lower back pain, and it got worse recently, and actually just this past weekend, it started to go down the leg.
Yeah.
So I went into the doctor the other day, he did x-rays, et cetera, and he hasn't finished everything, but he said the initial finding looks like lower back arthritis, which I don't think there's a cure for. So in terms of long-term maintenance and whatever, is that something that your company would address, like you have to do physical therapy? I mean, other things, I'm not sure, I didn't get through the whole process yet.
Yeah, and typically what they're talking about with low back arthritis, they're actually talking about the space between your discs. And so you can get what's called degenerative disc disease, or DDD, where the space between the 2 vertebrae actually narrows, and it creates arthritis. Well, what's narrowing is your disc, and so sometimes that disc can push on the nerve, causing pain.
Well, that's probably what happened, I guess.
Yeah.
But that's something that you could do.
Oh, absolutely. Yeah. Like I said, we have PM&R providers that can do injections, and then if or when surgery was ever required, if that were to be, then we have an orthopedic surgeon, Dr. Michael Anderson here. These are all great questions. You guys have any other questions? Well, thank you very much for your attention, guys.
I'll make sure that Scott gets the slides, and that way if you need them or you'd like to look at what he's presenting, you can get them from Scott, or I'll have him send it out or whatnot. So, and then there's information for Taylor. His card is back on our table, along with information to get a hold of